convincing a patient who, is telling me they inject drugs, but to receive syringes from the VA, it's a hard sell. And I have to think that I would probably be in their shoes too, knowing that would go in my record, and those records get carried forward like years, copy paste. We were troubled because we hear about the importance of lived and living experience and harm reduction, how it was those are the people who started harm reduction. But it seemed to us three that it was just kind of completely cut out of the equation in terms of implementing harm reduction into healthcare.
You're listening to Narcotica, a podcast giving you the straight dope about drugs and the people who use them.
People don't usually associate drug use with the military, or view people who sign up to go fight America's wars as people who might use drugs. The stereotype of crew-cut hair, pressed uniforms, and standing at attention really doesn't line up with the way we have been conditioned to view people who use drugs. But, as a matter of fact, there's a lot of drug use that occurs in the military. It just happens below the radar. It's a don't ask, don't tell situation. Anyone who uses drugs in the military keeps it a secret under threat of losing their contract with the military or even being incarcerated in a military jail. As a result of this, we don't really know a lot about what drug use looks like in the military, but we can make a pretty safe assumption that anyone who does use drugs will lack access to many of the basic life-saving harm reduction services. I'm Aaron Ferguson, and you're listening to Narcotica. Today's episode is an interview with someone who has taken these questions seriously and has been working for years to expand access to many of the life-saving services that civilians have enjoyed for decades. Beth Dinges is a clinical pharmacist who's been caring for veterans for over 20 years. She's the harm reduction coordinator who helped launch the VA's first Syringe program in 2017. And she works directly with veterans prescribing medications for people who use opioids and to treat hepatitis and prevent HIV. Just want to take a brief second before we get started here, though, to remind folks that we are a listener-supported podcast. We're very passionate about the topics that we platform, and we're doing everything we can to keep this show chugging along. But we can't express enough thanks to those who have taken an initiative to make sure that this show is sustainably supported financially. And we welcome anyone else who might be interested in supporting it as well. You can do that through Patreon, or you can give the show a good review on Spotify or iTunes or some other good platform. Without any further ado, though, we bring you Beth Dinges. I'm Aaron Ferguson, and you're listening to Narcotica. Really excited to have Beth on the show today. Also, we have Troy Farah, who you all know well. Say hi, Troy.
Hey, how's it going?
Thanks so much for joining us today, Beth. I've been wanting to have you on here for quite some time. How are you?
I'm good. I'm such a fan of this podcast, so, it seems a little surreal that I'm on it, but thanks for having me.
Thank you. We're honored to have you. So starting from the very beginning, I met you through a mutual friend, and I had the experience of having been in the military. I don't talk about it a ton, but I did serve in the military for a while, and it helped me out in life. I had a rough upbringing. I grew up in a cult. I didn't know how to make my bed or brush my teeth or any of that stuff. I was living on the streets as a kid, and I saw a bunch of my friends going to prison. So I went off and joined the military instead, and used drugs a lot while I was in the military. I didn't have access to harm reduction services. So I spoke about that a little bit, and someone connected me and Beth because Beth was interested in getting a board of people together who are working in harm reduction, who have experience from being in the military. This was something that was lacking. So that's how the two of us connected, and we're part of a national board of people with lived and living experience of drug use, who are also veterans. And so I'm excited about this conversation today because we have an opportunity to explore something that really doesn't get talked about a lot. But to start from the beginning, Beth, how did you start getting involved with harm reduction as a whole at the VA? How did that come about? Was it a difficult fight? And then how have you seen things change since, what was it, back in 2007 when you first started? Are things rolling back or moving forward? Yeah, if you could just kind of give us a little bit of a summary.
Sure. Yep. Graduated pharmacy school back in 2005, and I was familiar with the concepts of like syringe programs, like very broadly. I was always like just kind of neutral about them. Yeah, if someone needs something, sure, why not? And so my passion has really like changed over time, ignited. But my first introduction was back in 2017. I work at a pretty rural serving VA. And we had a veteran who was infected with Hep C. He was aware of it, and he was looking for syringes for both he and his partner. And he couldn't access any where the facility is in the surrounding community. And that's kind of true to this day. But he was asking for syringes, and I think sometimes the typical way with the VA can be like, no, we don't do that here. So unfortunately, he got sent away. But he did get connected to have his Hep C treated though. And we did actually get him connected with syringes through Chicago Recovery Alliance. But it got us looking into whether or not we could provide syringes through our VA. And we did that. Some folks, I didn't know, I never got to meet Dan Big in person, but he was instrumental in getting us set up with a supply of syringes that were donated through public health to our VA, because we were under the misimpression we couldn't buy any syringes. So we got started with a donation. I thought that we couldn't buy syringes. It was just like this big, broad no federal dollars for syringes intended to inject drugs. But turns out that was wrong. And in 2019, I think just as a fan too of like the folks at Network for Public Health Law, I'd reached out to them with like a semi-related question, but they were kind of like, wait a minute, why are you having syringes donated? Why don't you just buy your own? Like, well, we can. But they explained that to me. And maybe a year plus later, we got official guidance through the VA, basically like agreeing with what they were saying, that federal prohibitions on to purchase syringes really only applied to certain federal departments, not all of them. So when we got that like official guidance, I think it was in 21, that VAs could purchase syringes. Like I think that really got me. I Once I got exposed to all that, I never wanted to go back. But that was my start. But yeah, a patient coming in for syringes, he got turned away. We got syringes donated through the community, and later found out we could purchase our own.
Let's get into some of those challenges that you faced and what were the results like now that the VA has been able to offer syringes, like what were you seeing with your patients?
Yeah. So after that, like official guidance came out in 21, I feel like the uptick in other facilities providing syringes really took off. I think that there's now maybe over 50 other facilities that offer their own programming, and many of whom collaborate with communities, like organizations too. But yeah, I think that was really like the start, like 21, when it's official that we can purchase these items.
Are you seeing improvements in people's health? And like a follow-up question is like, are you worried about this progress being erased? Because I see a lot of attacks on syringe access coming from the federal government right now, and there's sort of this kind of right-wing backlash against the whole thing, which is a little insane to me personally, because it's just such common sense. Like it's a common sense health intervention.
Yeah, and like our desire to provide syringes is really just like right looking at the evidence and realizing that aligned with like VA goals to like keep people safe, prevent infections that don't need to happen, or after we spend a lot of money to treat someone's Hep C, like it's to prevent them from getting reinfected and having to a lot of money to retreat them. So it just made a lot of common sense. And I think I was fortunate that one, I'm in Illinois, where state laws are pretty harm reduction friendly. and just like at administration wise, I think it was a good time to like get this piloted and get it launched and growing. But of course, I'm scared of where things will go. We haven't been given any like internal direction to stop what we're doing or that anything needs to change as of yet. But yeah, I think most people are a little fearful of where it's going to go.
Yeah, it's pretty crazy to me that no one had thought of this before. Frankly, it seems like this is a pattern with harm reduction as a whole and just drug user health. I mean, I think naloxone was sitting around for a very long time before anybody figured out its utility or thought to question the laws regarding it, thought to question its availability. And how long was it an option to buy syringes for service members before anybody asked the question, like, hey, can we do this?
Exactly. And I was even like told by like, general counsel, like you cannot buy these. You can have them donated, but you absolutely cannot buy these. And I just didn't question it, right? I'm not a lawyer. And
I remember hearing that saying in the military, though, you have to hear no 10 times before you can get a yes on anything, literally. Because the default answer is always no, because it requires extra paperwork and work and bureaucracy. I guess, it's interesting to me the difference between how something like this would look for the military versus the general public. It just seems like there's so much more red tape and there are so many more cultural barriers to get past. We have all these expectations about our service members that don't seem to really align with the nature of reality. Do people in the military use drugs? I think it's just as ubiquitous as everywhere else, but it's not something that we acknowledge unless someone is out and they have a diagnosis of PTSD and it's like, oh yeah, now they're medicating. But people who are active duty, I mean, there was all kinds of drugs when I was in the military, and it just seemed like it was very don't ask, don't tell. No one acknowledged it. It's like, if we find it out, we're going to kick you out. So everyone was very secretive about it, but it was very commonplace. And that happens in the general public to a certain extent. We're all kind of pretending that drug use doesn't happen. We're all kind of pretending that it's something we can prevent kids from ever doing. And that if they do, we can just force them to stop. But it seems like there's an additional layer of that, in the service. And we've discussed that a lot, with the board, with different people who have military experiences. What would you say are some of the main differences between doing this type of work for people that do this type of work just in the broader community and then trying to do it in a military setting?
that's an excellent question. And I have to step back because I'm always like when our board meetings, when I hear discussions around substance use in the military, they're just like fascinating to me. And, I'm 20 years in the VA, but I don't think I would last a day in the military, really, truly. But, and it makes so much sense too. Like those are really like harsh settings. And of course, people are going to like reach for substances to help them cope, right? It just makes so much sense. And I can't, and it's like, it's also hard for me too, because all I know is the VA and I've not worked outside of it. And so I'm kind of in a way used to, I feel like it's abnormal if someone doesn't have like coexisting, like with their substance use, like some sort of like trauma, maybe military sexual trauma, like chronic pain, like heightened risk of suicide, maybe some housing instability. For me, like I guess I get kind of used to when I see patients that those added layers. And I'm guessing that probably there's not as much of those like concurrent conditions going on outside of the VA veteran population.
Yeah, and it seems like there's a difference in the way people access resources. And I know we've talked a lot about discharges, and there are people who have served for a number of years. I had another than honorable discharge. I decided I didn't want to be in the military anymore. And I went AWOL and came back and tested positive for marijuana, and they used that as a reason to deny me any benefits. So it's an issue where you have some people that have access to healthcare because they have an honorable discharge, they completed their enlistment, and then other people who serve 3 years or even two enlistments, but then prior to the end of their current contract, they broke military law, which is there's this, we all learn like there's general law and then there's the UCMJ, Uniform Code of Military Justice, which is an additional legal parameter that you have to follow when you're in the military. And it's a lot like more strict. It's a lot more on your ass, right? Like literally they own you. They can call you at any time and say, hey, you got to go. And you have to go. And if you don't, you're breaking the law. So it seems like there's some people who have access to these resources because they've been compliant in the military and they've completed their enlistment. But then there's a whole other population of people who don't have any health coverage. The military has wiped their hands of any responsibility for them. And has there been a shift in the way the military views drug use for people who've no longer have access to those resources, who got a other than honorable discharge, who've been cut off from military benefits? Has there been a shift towards addressing mental health over time? Is that more of a focus?
That first of all, that whole subject of like other than honorable OTH discharges, like it was wild to me. Like, and I learned so much, recently looking into it. It's still like kind of like it triggers me when I talk about it because it just doesn't seem right. But I know that there has been progress movement to open up like crisis care for veterans with OTH discharges, like around mental health, like suicide. But it's temporary and it's not comprehensive care. And it's not like those people still fall through the cracks, right? It's like a lot of times you don't know about it or you don't have the bandwidth, right, to like pursue it. It's not like this automatic in. There's still paperwork. And so I see how people slip through the cracks, even if, there's been recent movement to try and expand access, even temporarily. Because it's like I didn't know that like people with those type of discharges were at increased risk of suicide, overdose, incarceration, more likely to be unhoused. So arguably, like those are the people that need more help, more assistance, right?
Yeah, I can't count the number of people I've met who are experiencing homelessness or unhoused, and they served. They served in the military, and now they're unhoused, and they have no health coverage. The military doesn't give them any benefits because they got kicked out for some reason or another. Usually has to do with drugs.
I'm curious, Aaron, since you brought up cannabis, like, how that fits into the military in the modern day, because we have such crazy laws across the country that, it's like it's legal where I'm at in Illinois, but I can go 20 minutes to Iowa and it's a felony for having a gram. So I don't know how that works for a lot of veterans. I know that cannabis can help with some PTSD symptoms. And there's even, Dr. Sue Sisley from Arizona was doing a lot of research on trying to use cannabis to treat PTSD, but it became this huge legal fight because they just really didn't want her doing this research, and she just had to fight for it so hard. So can you give us a little bit of an idea, Beth, about what cannabis use looks like in the military?
I can't speak for the military. I will say that like in the VA and just in, clinical practice, I have seen it become normalized like it has outside of healthcare too. Like I remember, 10 years ago that I feel like it was quite the norm if someone had cannabis present in their urine, that meant long-term opioids stopped. And now I feel like it's become more mainstay, and that it doesn't trigger this like what can be a harmful reaction of like cutting off services, like for like potentially destabilizing people.
Yeah. And as far as the military goes, I think the views have changed a lot as well. I mean, from back when I was in, it's been quite some time ago. It was a non sequitur. Like if you used any marijuana, that was totally disallowed, even though everyone did. I mean, everybody smoked, but they would do random drug screens, and you would usually find out ahead of time. Word would get out, hey, they're about to do this, and everybody would go out and take a drink and hope they could pass it. But I think now it's like, as Troy says, it's different everywhere. You might live in a state where it's legal. So, the UCMJ is obviously like this additional layer of legality to the general law, but it's so common. It's like everyone's smoking it now. I just don't think they can enforce the traditional way of dealing with it. And so they've had to change their approach as far as deciding whether service members can smoke while they're in the military or not. It's kind of like alcohol, right? I mean, alcohol is obviously a drug, but it's part and parcel of military culture. It's almost like you're not trusted if you don't go out and drink with the guys. And it's just become commonplace. It's just something that everyone does, mostly because it's legal, right? It's a thing that you can do. You get your paycheck, you get your little BAH allowance, and then you go out and get smashed. When you pull into port, whenever you get a chance to spend some of your money, you just go out and get smashed. And people are going to do whatever's there and whatever's available, as much of it, and I think military doesn't want to lose people. At the same time, it's like a trade-off. It's like, okay, we can't just kick everybody out because we're short on people who are willing to go over here and fight wars for us and be part of the military. So I think they have had to shift to a more lax viewpoint, at least when it comes to marijuana. Obviously other drugs, it's a totally different conversation. And when we're talking about syringe exchange and we're talking about some of these like more advanced harm reduction practices, it's been a real challenge. Can you talk a little bit about the harm reduction engagement board that we've been working with and some of the projects and discussions that we've had there?
Absolutely. So my colleagues, one an infectious disease physician at Orlando and another pharmacist in my same position at San Francisco, we'd been working closely over the years. Each of us were kind of like early adopters getting into this world of harm reduction. We were troubled because we hear about the importance of lived and living experience and harm reduction and how it was like, those are the people who started harm reduction. But it seemed to us three that it was just kind of completely cut out of the equation in terms of implementing harm reduction into healthcare. It just seemed like it started to become, harm reduction started, as it became increasingly adopted, it seemed to be just treated like the same old protocol as we would treat diabetes or primary care, and just very top-down, clinician-directed, and no real input or involvement of the people that it's affecting. And we would see top-down decisions that were obviously made without that input in the detrimental effects of that.
Yeah, that concept of nothing about us without us is really at the center of it, because the practice itself came from people who use drugs, right? But I'm sure that there's a set of practices that's even different among service members with regards to harm reduction, because you have to not only you have to figure out a way to get access to all of these supplies and services, but you also have to figure out a way to insulate your employment and protect your employment, because your employment is so tied to your use of substances. And everyone's employment is tied to the use of substances to a certain degree, but it's to another extent in the military, because your entire contract, is based on this agreement that you're not going to use certain substances, and you're in breach of that contract if you do. And not only that, but you can wind up in the brig, which I spent several months locked up in the brig. It's like the military jail or whatever. And so no one wants to do that. The brig sucks, especially on ships and when you're forward deployed, the brig is like horrible conditions. And, so people really take it seriously. To me, that's a conversation that's lacking if we just treat harm reduction as this, okay, well, it's just like treating anything else. We'll just give them these sets of tools and supplies that they need, not really engage people in a conversation about community, basically, with regards to drug use. So I've enjoyed being part of this board. We've got people that are involved from all walks of harm reduction throughout the country who have lived experience and are working in harm reduction. And this thing just formed about a year and a half ago. Do you want to talk about some of the stuff that we've done as part of the board over this time?
Yeah, absolutely. And I'm so in awe of what all of our members have done. Just really cool, harm reduction work. They're in it, and they bring that military experience and then all that personal life experience too. And we were very intentional too, about we didn't want it to be another like recovery board. We wanted, representation from living experience on the board. But yeah, so let's see, some of the things that we've done are some of the board members have been on like national VA calls. And it really was like, yes, that was a step forward, but also to like just look at it, it was really like the first time that we ever had, in, I don't know, 7-8 years of VA harm reduction work. It was, I think, the first time that we had someone with like lived experience, like talking about harm reduction, someone other than like a VA clinician or other subject matter expert. Don't get me wrong, like subject matter expert in your own respects, but like having that presence on national calls, we have presented at a number of like addiction conferences and done a couple of journal submissions we're waiting on. And also just like, input from other VA's facilities that are just getting started with their programming about like, input on, what do you think of this order menu? Or what do you think of this handout we're proposing? We've developed a number of like educational handouts like within our group too, like on how to use drugs safer when you're alone, or one on chemsex recently. And those are all materials that, they'll have the VA logo on it, and they have like, in collaboration with our board, and things that get handed out, printed off and handed out at the facility. And some of our members too, like really who do veteran outreach to the community side, non-VA side, but they really enjoy like handing out those materials and just talk about the power of, the VA branding on it, that, hey, VA is behind this. And I think we've done some powerful things in our year and a half together.
That's really interesting, especially about the chemsex one.
Yeah, I felt the need for it too, just like, being a HIV prep prescriber myself, and then always asking about substances too. So a lot, amphetamines and stuff like that. And just like, some conversation starters. I don't think we had anything like that in VA, like, library of patient education.
Do you struggle with like getting people on board with some of these programs? Like, it seems like I hear a lot of this like right-wing culture war stuff, like, oh, the military is becoming weak, all the soldiers are stoned or something like that. It's just, I don't really buy into that, but like, how do you get people to be on board and be like, this is actually going to help our veterans, and this is a common sense program. Let's talk about this sort of stuff rather than just keeping it to the shadows.
Like on a macro level, I think the timing helped when we got started and where we were at with administrations, and definitely like, what was that, ONDCPs, like when they announced like as part of their like drug policy strategies, like they one of the first times in history, like explicitly mentioned harm reduction and drug checking and syringe programs. Like that definitely helped as, yeah, broader call to getting like, higher up leadership like on board with this. And I mean, yeah, so that messaging counts for a lot, but even just like, I think a lot of clinicians just, I wasn't aware of the breadth of evidence either, just in terms of like, 50% decrease in new cases of HIV and Hep C. And I totally realize that harm reduction at the point is not to get people on, into recovery or onto treatment. But I mean, we have to be honest, and leadership likes to hear that. So when they hear that people are more likely to engage in treatment instead of vice versa, like that definitely helps too. Like local leadership, when I try and convince them. And then at the patient level, like I hate to call it a micro level, because it should be the most important interaction, but it is hard still. I feel like my conversations, it's an art, and I'm getting better, but convincing a patient who, is telling me they inject drugs, but to receive syringes from the VA, it's a hard sell. And I have to think that I would probably be in their shoes too, knowing that would go in my record, and that those records get carried forward like years, copy paste, and just potential stigma. Like if I were to have acute pain, you're treated differently. So I get it. And fortunately we have, I mentioned pretty rural setting, but we do have like a community public health, like 40 minutes away, that does like once a week, like deliveries. So making sure that they're linked up with the community.
Yeah. I feel like they must be conditioned to be afraid of talking about any of this, just because, I mean, it's one thing to like lose your job because of substance use, but like you're always at risk of being stigmatized. And I think there's a lot of soldiers, people in the military are, their identity is kind of wrapped up in this role. So anything that's going to diminish that. Yeah.
Absolutely. And no, yeah, I mean, there's already, I feel like the default, right? You're filling out any paperwork for any job is going to be no, no, no. But I have to think that that's heightened, like coming out of the military, and where it's just, right, when Aaron talked about that don't ask, don't tell, just like you say no and you cover it up, right?
Yeah, it's kind of tragic too, because most of the people that I met when I was in the service were just there to get funding for their college. Um, because otherwise, instead of take out a huge loan or go deep into debt to get a higher education, which we don't make broadly available in this country, it's kind of a privilege to get a higher education. So really a lot of people, I would say the vast majority of people join the military hoping to get money for college. And so it's like this trade-off. It's like, okay, I'm going into this environment and you got to buy it. You can't just go in and kind of half-ass it. It's like, if you're going to go in the military, you got to stand at attention, wear the uniform, cut your hair. Yeah, like Troy said, some part of your identity is changed as a result of that. And people from the outside, I think, look at it and see it in a different light. They're kind of like, wow, you did that. Um, or I hear all the time from people like, you don't look like somebody who would be in the military. You don't seem like someone who would be in the military. But it's a decision that people make to like better their lot in life. And in many instances, because they didn't have any other options or because the other options were not the best. But there's also classism in the military as well, because you have officers who come from a different caste essentially, and there are people who have already graduated from universities and decided as part of their career, from Harvard and Yale even. I met service members. I went through Navy SEAL training when I was in the military, and I got a chance to meet people from all of these elite universities who wanted to be Navy SEALs, who were officers, and they had such a different path in life than me. It was unreal. So it's like a melting pot of all of these different strata of society, but there is a unifying factor, which is substance use. Everyone goes out and drinks and they're all using drugs. Like, let's be honest about it. But we haven't been, right? And you talk about suicide and you talk about PTSD, you talk about, these are the people that go out and do the dirty work. They're doing the things that we don't hear about. And they're coming back and having to figure out how to be part of our society and find a job. You mentioned like filling out an application and having to, what relevance does your military experience have to what you're trying to do? Being an engineer in the military doesn't mean you can go and be an engineer. It's a totally different job. So I hear you when you're saying you have to figure things out with these people, because in the VA it seems like the VA deals with people who are active duty and people who are inactive, and in those two different settings, you have people who are coming out and trying to reintegrate with society, and the social determinants of health barriers that they face can be pretty steep. And so, but you're figuring out a way to engage with them at a level that they'd be willing to receive these services actually from the VA, which I think is a unique setting, because it's different from somebody walking up to a syringe exchange on the street in the back of a parking lot of a grocery store somewhere because they received a schedule. Like, they're going to an institution itself to get these same services. What do you think about that? Like, what would an ideal scenario look like? Something that people would actually engage with. What would the ideal setting be to actually increase uptake? To make people more willing to say, hey, I'm going to care about my health, instead of just hiding this thing, buying syringes from a pharmacy or reusing them.
I do think that and it's like, I don't know the military world that much, right? I know the VA world, but like, I definitely think like integration, like when you're leaving the military, that would be a prime opportunity. to like offer these services and like, hey, they're available through the VA. But I think too, though, about all the people with like OTH discharges who are just kind of like, those people aren't monitored or followed longitudinally. And so I just feel like it's kind of like you're out and then there's no tracking. Where in a perfect world, I would love to see like, hey, you're struggling with substances, like here's how we can get you help, and that there's actual coverage for those things, and that there's some kind of safety net. But I just feel like that wouldn't be like the prime target. I said I feel like those people are kind of whisked out the door, and then no one really tracks what happens to them. Like in my ideal world, like those veterans would have at least like in my world, I would, they would have access to comprehensive VA healthcare, but at minimum, like harm reduction services, even if like they weren't, eligible for other ones because of like a OTH discharge.
I mean, should we have syringe exchanges on every base? Should they set up should harm reductionists just like set up outside of bases, or should the VA have like its own arm, its own branch of that's called, the harm reduction branch of the VA where they can send people off to if they're using drugs?
Is that maybe somewhere that peer specialists come in?
Gosh, it's almost like opening up this like kind of Pandora's box on peer specialists, because I feel like they have so much potential to help in VA harm reduction, but there's also limitations on what they can do functionally with their job. Like their job doesn't allow them to do a lot of this stuff. But yeah, in my ideal vision, like I would, peer specialists that could help, like especially during integration, like help veterans, including ones with like OTH discharges. Like, hey, the VA has these services available. We can get you screened. We can get you treated. We can get you supplies.
Yeah, well, hopefully we can see some of those changes if we get more. I think, as we've talked about, getting more people with experience involved to actually directly reflect the needs, the stated needs and lived needs of people who receive his services.
Yeah. And at times of frustration, I have to step back and look at the progress because 8 years ago, we didn't have any syringe access, or at least not formal. But yeah, we've started our program in 2017, and we've gotten like legal clarification that we can, syringes can be purchased, and mentioned, some formal written guidance to support it. And there's now over 50 facilities with their own programming. So that's helped. And along the way, a lot of those same VAs also offer drug checking strips. And some have been diving into like safer smoking supplies and really expanding it. I feel like, naloxone has always been kind of a powerhouse of the VA for probably like 10 plus years now. Like areas where I would really like to see it expanded, improved is like, a lot of harm reduction items, naloxone included, are by prescription only. And that you got to get a prescription from someone, and then there's chart documentation. So I think all those can be like implementation barriers. And, my dream is that I would, see like naloxone available without like under a standing order, without a patient specific prescription.
Yeah, that's crazy to think about, because that used to be the only way you could get it in the general public, and now it's available over the counter. It seems like that almost happened overnight to me, because for most of my life, it was actually illegal to even have it. The first time I ever saw Narcan, a friend of mine was being arrested and the cop was telling him he's not allowed to have it. And like going from that to where police officers are carrying it, but having to even fill out a piece of paper in order to get it, even having to fill out a survey, will often wind up with just boxes and boxes of it sitting in a warehouse somewhere and not winding up in the hands of people who use drugs when it's totally safe. I mean, you can take this shit. I could take some right now and keep talking.
Yeah. Another challenge where I run into a lot is like veterans who received housing services. A lot of them are OTH discharges, but they're not eligible for medical care. So they can't get naloxone through the VA, even as a prescription. And then like where I practice, it's pretty rural community. We do not have naloxone saturation. And there's a lot of overdoses in those housing sites. And that's something that makes it a little hard to sleep at night, knowing that they don't have like ready access to naloxone, whether it's through the VA or community. So that's, I think, part of that kind of that ideal vision where, like, if these veterans, if they're not, don't get comprehensive medical care, at least open the gate a little bit for things like naloxone.
I mean, who tracks overdoses in the military? Is there like some separate system for figuring out what rates of overdose are? I mean, if I had to throw a rock at it, I would say it's higher, but is that something we even measure?
It, I mean, for the VA, yes, but I think it's only veterans that have like those all those OTH discharge and stuff like that. They don't count in those metrics. Like they don't get tracked, and we know that their rate is higher. But it's also something just that data doesn't get released very often. I haven't, I feel like it's been a few years since I've seen like at least for on the veteran side, the number of overdoses.
That's crazy. The military in general is very protectionist with just data in general and information about it, about service members. I think a lot of it has to do with just saving face. You know, I've had friends who like got into trouble and they just kind of swept it under the rug because they didn't want a bunch of people to find out. They didn't want to bring bad publicity to their command or bad publicity to their branch.
Yeah, and I feel like it's kind of like don't ask, don't tell, but on like a macro level, right? At the individual level, you sure as hell don't say anything, but also just like, yeah, I don't feel like there's that much transparency.
Because we hear about suicide a lot. There's been a lot of focus on that, and rates of veteran suicide. But, accidental overdose is, it's a totally different ballgame. But we know that, I mean, it's the leading cause of accidental death for Americans in general. Why wouldn't it be the same thing, for our service members, at least below retirement age? It doesn't seem like. That's why I asked, are they even being measured? Because while we talk about suicide and mental health, we're not talking about something that's probably an even greater risk of mortality for a lot of service members. So naloxone availability has expanded. Are there vending machines?
It's kind of like that the prescription thing. Like yes, it's always for naloxone, but sometimes it could be also for like syringes too, which obviously can be an access barrier.
So you go to your doctor and you get them to sign something, and then that goes in your medical record.
Yep. Yeah. There's still, I mean, we started our program and we still have it going that you can access them. We've kind of found ways to get around it where people can access them without a prescription. But yeah, for a lot of facilities, it's still it is the norm that you need a prescription. And then in states where like SSPs essentially aren't allowed, like a lot of the southeastern states, but also like, to my neighbors in Missouri and Indiana, there's no federal supremacy over state and local laws. So VAs in those 6 or so states essentially cannot offer syringe access. So that's another good chunk of people that get left out, which is unfortunate. But yes, I have a vending machine purchased for our facility. I'm very much working on getting that live, but like our co-lead for our board out in San Francisco, has at least 10 or maybe 15 vending machines across their VAs, but also like the housing sites. That's really nice. But to this date, we haven't been able to put naloxone in there.
Oh, well, I mean, it blew my mind to see that there was even a group of people doing harm reduction at the VA, because that was completely absent when I was in the service. And so we have made some progress. Really grateful to people like yourself, Beth, who have taken the initiative to question, like, why can't we buy syringes, or why couldn't we do this? I think that takes a lot of courage, because there's this climate of status quo that permeates everything to do with the military and military healthcare. And it takes someone with their own moral compass to do harm reduction in general, let alone in a setting where there's that staunch status quo attitude. So it's really great that you're doing this. I appreciate you being willing to share some of that with us. How can people support this work that we're talking about? How can people support the availability of these services?
Naloxone is available as a prescription, no cost at every VA. Like, so just like telling veterans that, and also just like Hep C treatment and HIV prep, or getting, tested, screened. And yeah, I mentioned over 50 facilities with like syringe access, and most of them do like drug checking strips too. I think if you're like, I imagine you have a harm reduction heavy audience here, and if they work in like with community organizations or even public health, like I think there could be a lot of opportunity. Even if you're in one of the, like, if you're in Texas, I think that there's great opportunities for collaboration with the VA, even if, that VA can't provide syringes, but just like, my ideal model is also like this bi-directional flow where like, hey, maybe our VA can't provide this, but here's direct linkage to, a community partner that can, maybe. And maybe that community partner can't treat your Hep C, but, so just that collaboration and connection. And I'd be happy to be like a triage, if people were to reach out to you or directly to me, to put them in contact with people in their local VAs.
Yeah, how can people find you?
I'm happy to have people reach out to me directly. I think we do have like an external facing like website, some of the work that me and my colleagues have done, including about our board too, that I can provide.
Yeah, we can include that in the show notes if you have social media you want to share as well. I mean,
And we're looking for people with living experience who work in harm reduction or have knowledge of harm reduction to get involved with the board that we mentioned, or at least to help create community, because there's really very little community for our service members who use drugs. And isolation, social isolation and depression are probably as dangerous, if not more dangerous, than just using drugs itself in terms of risk of overdose and a bunch of other health risks. So we want to create a place where people can reach out and find community and support, maybe even if their goal is not to stop using drugs, or if their goal is not to get into treatment, or they're not interested in recovery. They still deserve to be able to connect with other people and be validated for their drug use, or be validated for their desire to be happy and pursue health. And so if you know anybody who's involved with that, you could reach out to me or Beth, and we'd be happy to connect folks. Is there anything that we've left out, Beth, that you think would be interesting to discuss, or that you wanted to bring up or add?
I mean, there's been a lot of progress over the years. I hope it doesn't reverse, and even if we have to take a little slowdown, that we're still moving forward. I do think, and it's also like, right, the culture at healthcare, generally speaking, too, is very abstinence based. But I have seen subtle shifts at our own facility too, where it's, that you can come here if your goal is not abstinence, that there's still room, we can still see you and help you. And thankfully I have a excellent relationship with our addictions psychiatrist who fully recognizes that. But I do see little cultural shifts too, changes, where it's okay to come here if like your goal is not abstinence.
That's great.
Yeah, I'm really happy to see those changes happening, and I hope that they continue even despite all of the negative rhetoric that's happening. I hope that, our service members can recognize that these resources exist, that the word can get out, whether it's word of mouth or whether it comes through the VA, that people can start accessing some of these life-saving tools. Well, thank you so much for being willing to chat with us today, Beth. Really appreciate it, and the work that you do. We'll definitely be seeing you out on the barricades. Thanks for your time today.
Yeah, thank you.
Thank you both.
Thanks for listening to Narcotica, an independent production by Narco Media. Co-hosted and co-produced by Troy Farah, Aaron Ferguson. If you like the show, you can find out more at narcocast.com and support us by joining our Patreon. Just go to patreon.com/Narcotica. Patrons get free stickers, which are personally mailed to them and can request a shout out on the show. And now patrons can even get 30% off of merch in our new store, which is at narcocast.myshopify.com. We have t-shirts and coffee mugs, one that says there are drugs in here, which is awesome. More stuff will be added soon. As always, we're so grateful to the folks that make this show possible. I mean, really, a little goes a long way, so thanks for making Narcotica keep going. We're ad-free. We want to keep it that way if we can. If Patreon isn't for you, that's fine. You can help us out just by spreading the word. Tell all your friends about the podcast, advocate for social justice, and abolish the drug war. You can also rate us wherever you get your podcasts, and that helps the show get a boost. Our theme music is by Glass Boy, and Jenny Shea's the voice of Narcotica. Additional music's by myself, Nomad1. And you can follow us on Spotify, iTunes, Twitter, YouTube, Facebook, Instagram, SoundCloud, YouTube, all good outlets. Those are the best ways to try to contact us as well if you have a suggestion, complaint, or if you just want to tell us nice things. That's everything, folks. Hope you have a great week and stay safe out there in the drug world.